Is it just a minute?
Not audible?
Yes, sir. Sorry, it was my mistake.
Yeah. Good evening and good morning to Scott. So
good morning. Good evening.
So today we are going to deal with a topic. It's a different social and ethical approach to palliative care, and you can see Dr. Scott Berry is ready in his morning time, and he's a friend of us from Canada, from Queen's University. He's actually a medical oncologist, but he has been he is the professor and department head in the Queen's University Department of Oncology. But I believe he has now moved on to another position. But Dr. Berry, he is an active participant in clinical research in GI cancer. He is the co-chair and co-chair of the GI disease site group of the Cancer Care Ontario Group programs in evidence-based care. And actually, he loves a lot of teaching, and he has won several teaching awards. And he is one of the person who is behind this global fellowship, who is actively helping us in many ways. And we already talked about our association with Queen's University and friends there. He was the past chair of Royal College of Physicians and Surgeons of Canada. And his current focus is on medical education, working with international partners to improve global capacity in oncology. And he is academic interest is in bioethical issues surrounding the care of people with cancer, in particular, the ethical issues surrounding funding new and expensive cancer medication. We know this is a problem. And Dr. Berry has a master's degree in bioethics from University of Toronto. And he is the former ethics advisor to the Pan-Canadian Oncology Drug Review and has served on ASCO Ethics Committee. And moreover, he is a great human being, helping us in a lot of ways, supporting us. So thank you, Scott, for your presence, and it's over to you. You are not audible, Scott.
There we go. Well, thanks very much, Sunil. And I really appreciate the kind introduction. I am actually going to be moving from Queen's University in June, but I will remain working with the Queen's Global Oncology Program. I will be continuing working with Palliative India on many projects. And one of the things that it's been a real pleasure to work on with Sunil and the rest of the team is helping to develop this fellowship program. And I was fortunate to meet many of you when this group first got together, and I'm really glad that I can have a chance now to actually participate in a session. And I think tonight we're going to be talking about, I'm going to put up my slides now. Let me see here, Gina. Can you see my slides there?
Yes, Scott.
So tonight, I know you've already had one talk on ethical issues, and as Sunil mentioned, this is one of the areas that I'm interested in my academic life. I was fortunate to get a master's in bioethics from the University of Toronto, and they have a great program there called the centered at the University of Toronto Joint Center for Bioethics. I had my master's there, and I've done a lot of work in both teaching and policy around end-of-life care, the ethics of end-of-life care, and the ethics of funding expensive cancer medications. And so tonight I'd like to talk about some ethical issues in end-of-life care. And I think that, you know, I'm happy and I would appreciate actually if people were, gave their suggestions in the suggestions or comments in the chat. You're also welcome to put up your hand, and I'd be very interested in hearing your comments as we move through these issues. What I would like to do today is I have a number of things I'd like to talk about. Let me just get clear the screen over here. Oh, sorry. The joys of Zoom presentations. Here we go. So I'd like to talk a little bit about facts. Yes.
Your slides are not visible now.
Oh, okay. So it says screen. I am screen sharing. Let's try again. Stop share. Can you see my slides now?
When it was put in editable mode, that we could see, but when you put it in the presentation mode, we are unable to see.
Can you see that?
Yeah, we can.
Okay, so we'll just maybe go, we'll just do it in this format. So I'd like to talk about, just before we get started about anything and start talking about ethics, I'd like to talk about the difference between facts and values, because as physicians, we're used to talking a lot about facts and just understanding the difference between facts and values, because that's going to have a lot to do with what we talk about tonight. A lot of the discussions we have are about values that patients have, values that their physicians have, and how we interpret those. I'm going to talk about an approach to ethical decision-making, some ethical frameworks that people use to make ethical decisions. I'm going to talk about cultural issues in end-of-life care, and I think this is where I'd be really interested in hearing your comments, because in Canada, we are fortunate to have people here in Canada who are from many different places and many different cultures from around the world. And as we deal with issues around end-of-life care, we see a variety of different approaches to this. And certainly as we talk about this, I'd be very interested in how my approach and my experiences in Canada are similar or different from your experiences in India and other places where the fellows are from. I know that just like Canada, India is a country with many different cultures, languages, religions, and I'm sure that there are cultural issues there, and we'll talk a little about that. I'm going to go through a case then, and what I'd like to do then is maybe approach the case and get your input on how you would approach it using some of the frameworks, how those frameworks differ in applying the case. And I'd be then interested in talking about any interesting cases that you have. I think we have an hour and a half tonight till I think it's till 8:30 your time. So I'm happy to talk about any ethical cases that you have in end-of-life care. And then we'll wrap up. And you know, I'd be happy at some point to come back and do another session on just difficult ethical issues that you've been facing in your practice and discussing them. So this is the difference between facts and values. When we're talking about facts, and this is in science and medicine, we often talk about facts. And I don't think anybody would want to argue that this is the chemical structure of morphine. But values are different. And here's an example of a value-laden statement that morphine provides benefits for all patients. And I think that as we go through our discussions today, I'm going to push you and ask you sometimes whether what you're stating as facts or values. Most of the things we'll be discussing when we talk about ethical issues are actually values. And when we talk about values, there are multiple different opinions. And one of the issues is being able to describe your opinion, defend your opinion, and give evidence or support for your opinion on why that value should be the appropriate one to apply. And often that means applying a certain ethical framework or decision-making capability. I also know that many of you have a lot of experiences in this area, so I'm hoping to learn as much. I'm hoping to learn a lot from you tonight as well. So in terms of a checklist for ethical decision-making, and I think this is one way of looking at things. It's by no means a definitive way of looking, but I think this is the reference for this is down at the bottom right-hand corner. And I think that it starts with saying a sound ethical decision-making process may incorporate the following abilities, and it may incorporate others. But I think these are some of the issues that we want to talk about and discuss. And you may think of others you would think that would be appropriate to incorporate. And when we talk about the cases later on, these are the types of things I'd like you to think about and to apply. So just going through these, the ability to identify all related issues pertaining to the incident, issue, or dilemma. So having a full understanding of the case. The ability to sort morally relevant issues from morally irrelevant issues in any given situation. And as physicians, we often like to talk about medical details. And sometimes those are morally relevant, sometimes they're not. But I think it's very important to understand or to be able to sort out what are morally relevant versus morally irrelevant. And things can be medically relevant without being morally relevant. The ability to unpack the elements of morally relevant information. So once you've said these issues are morally relevant, what are the important ethical issues? Is it around autonomy, decision-making, consent, etc.? The ability and willingness to research issues and reflect upon them, the ability and willingness to seek advice. And I think this is one of the things I'm gonna, as we discuss the cases later on, think about the ability to form a well-reasoned, unbiased, and morally defensible conclusion in any situation. So, as I said, there may be different views and different values that inform your decision, but ultimately I'm going to be looking to you to provide a well-reasoned, unbiased, and morally defensible conclusion. The ability to justify a position and act upon it. So I think that's really important. And again, we can discuss how you do that and different frameworks for doing that. The ability to challenge one's own moral framework in light of recalcitrant experiences, and being in possession of a consistent moral framework. Let's look at the chat here. There we go. So I know that in your previous session, you discussed 4 basic principles of biomedical ethics. And this is actually one of the frameworks for approaching ethical issues in medicine. And I think that it's important to understand that it's just really one framework. I think it's, for many medical people and medical learners, it's really brought forth as the only framework for analyzing issues. And I think that it's important to understand that it's just one. I think it does have many benefits. So the 4 basic principles are respect for autonomy. Some important questions here. Does my action impinge on an individual's personal autonomy? Do all relevant parties consent to my action? Do I acknowledge and respect that others may choose differently? Beneficence. Who benefits from my actions and in what way? Non-maleficence or non-harm. Which parties may be harmed by my action? What steps can I take to minimize this harm? Have I communicated risks involved in a truthful and open manner? In the event of a bad outcome, can I avert the possible harm caused? And then justice. Have I identified all vulnerable groups that may be affected by my action? Is my proposed action equitable? How can I make it more equitable? And these are, first of all, not facts. These are values. And we can talk a little bit about the underpinning of these values. But one of the issues with this framework, which is called principalism, is that these values can clash. Sometimes in respecting somebody's autonomy, you may cause harm. And so which principle is more important? In some cases, in providing good for one person, you may, this may be inequitable for others, and how do you balance these different principles? So I think this is one important way of looking at or analyzing ethical problems, but it's just one of them. And I'm going to talk a little bit about some of the other ways of looking at ethical frameworks. And these are broadly characterized as consequential theories or consequentialist theories. The philosophic term is teleological theories. Non-consequentialist, the philosophical description is deontological. And there's some alternative theories. These can be virtue theories or other theories. And just maybe going through this, one of the consequentialist theories, and these consequentialist theories, as you might expect, focus on consequences or outcomes. Egoism is one of these. What is in my best long-term interest? Many of you may say that may not be an ethical theory, but that is one of the consequentialist theories. Utilitarianism is one of the primary consequentialist theories, or one that focuses on outcomes. And this is about what will bring the greatest overall good for all stakeholders. So what will produce the best outcome? What will bring the overall good? So these focus on outcomes. Consequentialist theories focus on outcomes. And so these focus on the ends, not the means to those ends. Non-consequentialist theories, or deontologic theories. Immanuel Kant was a philosopher, and he was really the one who, conceived many of these. And these non-consequentialist theories, as you might imagine, don't focus on the outcome, but really focus on important things like universal, being able to have rules that are universals, focusing on the means to an end, not the ends themselves, and the actions people take are important. So these are really focusing on laws, duties. Many religions have non-consequentialist theories. Many laws have non-consequentialist theories. It is wrong to kill. It is wrong to steal. It doesn't matter if those might bring about good outcomes, like a consequentialist. Consequentialists may say it's appropriate to lie or steal in certain circumstances if it brings about good outcomes. But a non-consequentialist would say that there are some actions that are always wrong. There are alternative approaches. One of these, Aristotle, was a virtue theorist, and he would focus on the person and the virtues of the person acting, and that the important thing to do is to ensure that people have the right virtues, and then with those appropriate virtues, that person will perform appropriately or ethically in those circumstances. Another alternative theory is called the ethic of care, or feminist ethics. And these really focus not on individuals and principles like autonomy, but focuses on families, communities, and how people make decisions together. So I think that, and again, these are all value-based approaches. None of them are right, none of them are wrong. They all have different value systems. And it's important when you're looking at an ethical problem, what approach you are taking, what approach the patient is taking, and what approach other people who may disagree with you might be taking. And it helps understand what you're trying to do. Now, another way of looking at this, I look at agent, action, and outcome. So non-consequentialist virtue theories look at the agent. This person has all the appropriate virtues. They are knowledgeable, trustworthy, virtuous in many ways. One of the issues around virtue theories is describing or appropriately ensuring that you have the right list of virtues and sharing on those, because as you can imagine, those are value-laden judgments. Non-consequentialist or deontological theories focuses on the actions and whether they are right or wrong, whether they engender respect for the person. And they will often focus on actions being right or wrong, no matter what outcomes they do, lying, stealing. A consequentialist would say that it's okay to lie if it brings about a good outcome. A non-consequentialist or deontologist would say that you can never lie because the action is wrong, no matter what good outcomes it brings. And a consequentialist or utilitarian would say that it's really all about the outcomes. And if you produce a good outcome, then that would justify the actions that brought about those good outcomes. I think the other important thing, if we get back to these non-consequentialist therapies and the principles, autonomy, for instance, is an important principle of medical ethics, but you can actually defend the principle of autonomy differently on whether you, on how you look at it. A utilitarian would say that autonomy is an important principle because respecting people's autonomy and ability to make decisions is what will bring the greatest overall good for a society or group of people. A non-consequentialist, Immanuel Kant said that a human being should never be a means to an end, only an end in itself, so that we must have respect for individuals, as individuals have intrinsic value and must be respected. And regardless of outcomes, that means that we need to respect people's autonomy. So a principalist would just say that autonomy is an important principle. A consequentialist would say autonomy is important because respecting people's autonomy brings the best outcomes for all in a society. A deontologist or a Kantian would say that autonomy is important because it means it's important that we respect people as individuals with intrinsic value and must give them the utmost respect. So I'm actually going to pause there for a second. Many of you have probably had exposures to different ethical theories and ethical decision-making frameworks. And before we get on to discussions of culture, I'm happy to see if there's any questions or comments. I must admit, one of the things about these is that these are based on Western philosophies, utilitarianism, John Stuart Mill, who is a British philosopher, Kant, deontologist, German philosopher, Aristotle, Greek. These are important world philosophers, but they're all Western philosophers. So I'd be interested in, if there are any other theories that may come outside of the, my experience and the Western experience, but maybe I'll pause there and see if there's any questions or comments.
Sir, actually, we are not exposed to these many frameworks. We were, at least I don't know about others. In undergraduate education, we are not taught
these frameworks. In your experience, had you talked about the principles of biomedical ethics, though, those 4 principles?
Actually speaking, after joining this palliative course only, I have studied medical ethics. In forensic medicine, we read ethics, but we do not apply clinically in case-to-base cases and all. And after in the palliative care only, I am learning more of ethics and ethical dilemmas and trying to apply some ethical framework, not before that.
Okay, that's great. I'm glad these are things that you're learning. Do these resonate with you, or do you think that do they clash with your personal experiences? Do they resonate? Do some of you start seeing yourself as a consequentialist or a deontologist?
Yeah, maybe I can. This deontologist resonates with me more than the consequences.
Okay, yeah, and I think one of the things that's really important as you look at ethical problems and as you deal with patients and think about different ethical problems is understanding your approach, right? And if you're a deontologist or a consequentialist, or just to make things even more complicated, there are different ways. I am probably what's called a mixed deontologist, which is a mixed deontologist it says that they're usually focusing on those issues of deontology, but sometimes they will be influenced by outcomes. So I think that I don't think you have to be one or all of these, but I think that different people have different approaches to these problems. And in societies and individual cases, there can often be a lot of disagreement between different members of the same family, different physicians, different individuals, and understanding their approach and how they're looking at this can be very important. Any other comments about how these different frameworks resonate, where you think you stand, your experiences previously, whether there's perhaps non-Western approaches that may be relevant to discuss as well?
Hello, sir.
Hi.
Hi, I just listened to your talk, and I just have a comment to make that sometimes I see that on the ground level, like a lot of people know the theory part of this. There are 4 principles and things like that. But when it comes to the ground and actually doing it for the patient, there is a lot of difference between what people know and what people actually do. It looks good on paper, but practice, no, not for my patient, and that is what I have seen. Like I had a very close friend whose relative was father actually, was actually an end of life. He had multiple myeloma, and then he went through. So he was admitted because he had severe pain. So very high-end hospital in Delhi. But he was not given any pain medications because no, this will not do good to your kidneys. This will cause respiratory depression. And his views were not respected at all. And this was in a very high-end hospital. So there's a lot of difference between practice on the ground level with.
Thanks, Priya. I think that's a very important point. And I think, we're all human. We all strive to behave in the most professional and ethical manner possible. And I think what that means is reflecting on these issues, thinking about what the right course of action might be based on some of these principles. I think sometimes bringing actions that reflect those principles requires courage. And sometimes we're able to do it. Sometimes, as you point out, there are just blatant hypocrisy that, what the right approach might be and that things aren't done. Sometimes we try and do the best we can, and despite our best efforts, we can't do it. But I think that part of today's session is just about thinking about these things, and through reflection and thinking about different approaches. And the other thing is, there is no one right or wrong way of approaching things, right? But thinking about them, thinking about how you're approaching them, how the patient is approaching them, and the family are approaching them, how your colleagues are approaching them, how your governments are approaching them. I'll talk a little bit about that later. And what you want to do as an individual to make sure that your practice adheres to your principles, and that in some cases where you want to advocate for different actions to bring about care that you think is more ethical. So thank you for that. Saru Philip pointed out that in current medical curriculum, the 4 principles are taught using case studies. And I think the nice thing about the 4 principles is it's easy. There's 4 principles. They provide a framework for discussing cases and applying, these individual principles. Sometimes it can be an oversimplification, but I think it is a good way for introduction to ethics. But I think it can be much more complex than that.
So one thing which I've noticed in practice is that out of the 4 principles, 3, that is beneficence, non-beneficence, and justice, are easy to be done because we are doing it. But when it comes to autonomy, it's very difficult because culturally in our place, the patients don't come forward to ask more about the illness, and their relatives most of the time don't want the patient to know, though they know probably in the heart of hearts that they've got cancer and they're having very limited time. And so we have to, knowingly go with that, because otherwise we'll be breaking that very delicate trust with the patient and the relatives, and everything breaks down. But it is not amounting to collision because we are very much aware of that. But at the same time, being a cultural thing, we go along with that until something comes up where we have to reveal to the patient that it is so. But most of the time, it goes very well. I mean, unlike in the Western country where the patient wants to know everything about his illness, and we are very open about it, and we talk about end-of-life care and things like that. But here, it seldom happens that way.
So thanks, Biju. Thanks for those comments. A couple of things. Number one, the issue around culture, and we're going to be discussing that in a little bit. That's the next part of my talk, and I'll bring back to one of your comments about this being a cultural issue. The second thing is that issue of how much, this is a classic problem in Canada as well. Often, as a medical oncologist, the patient's family will come into the room sometimes before the patient comes in and says, doctor, whatever you do, don't tell the patient they have cancer. I've been in situations where, and this is, where simultaneously the patients then come to me in the same family, where the family has come and said, don't tell the patient they have cancer. The patient will come to me and say, doctor, whatever happens, don't tell my family I have cancer. It will kill, it'll be horrible for them. So obviously, one of the things about ethical issues is that there are a lot of other issues that come in, right? The law, communication, etc. I think that the one thing I want to point out about that, though, is that if you look at that situation from, a family, one of the frameworks I brought up was called the ethics of care, and feminist, and sometimes this is called feminist ethics, which has said that the principle of autonomy, of individual liberty is often maybe, and I'm not is especially in the four principles, brought about as this really important thing, that the respect for an individual's autonomy is the most important thing. But the ethics of care, or feminist ethics, would say sometimes that, in fact, that's not necessarily the case. People don't live as individual islands unto themselves. They're a part of families, right? And that, in fact, in some cases, it may be a better approach. And I'm not saying, this is one is better than the other, to approach a family as a family making decisions together. And in that family, it may be quite appropriate for, the person not to know, the family to make decisions. But I think, that it often means, as I said, communication will sometimes bring that out, right? The individual may, and this can sometimes be, say, people from that culture, and there are many different cultures in Canada, there are many different cultures in India. People from that culture make decisions in that way. I think that can be, you have to be careful of that as well, because I think that many people from that culture may make decisions that way, may have more of a focus on family rather than individual autonomy. But individuals within that culture or that society may make issues different. So a lot of this is communication. Certainly, people have the right not to know things. People have the right to say that I would prefer that my family make their decision for me. But these are the complex issues that we have to deal with. So thank you for bringing that up, and we're going to discuss a little bit more about culture. Sarah brought another point up in the text, or in the chat, that it's contextual. Most times challenging, not able to say what is correct and what is not correct. And I think that's a really important point, that the details of the case are really important. Family, culture, individual, the details are really important. And there are, again, I gave you some very broad overviews, but there are in fact groups of people. There is one, Joseph Fletcher, one philosopher, said something, had an approach to ethics called situational ethics. And he would say that in fact, and this is called, another name for this is casuistry or case-based, and case-based ethics. And what he would say is, in fact, you can't make decisions on broad principles. You actually have to get down into the details of the case. And for that specific context and for that specific case, the criticisms of that type of decision-making is that you can, if you get down to that detailed level and say it's always contextual, as a society or as a group, you never have any norms that, you know, that the things are so variable that you don't have a consistent approach. But I think that's an important point. And I think these are complex issues. And I, you know, as to the original thing is, I think that we try and do the best we can, and we try and be as principled as possible. We try and have a principled approach, but these are complex issues. So maybe I'm just going to move on here, because eventually I would like to get to some cases. I'm going to talk a little bit about culture, and Biju's already introduced this as a topic. And it's very important. And this is just a few slides about culture. I'd like to acknowledge one of my colleagues from an ethicist from Toronto, Mount Sinai Hospital. And he said that cultures, and this is talking about cultures are maps of meaning through which the world is made understandable. So in terms of cultural aspects of the ethics of end-of-life care, you know, to truly respect a person's choice, we must respect their cultural perspective. Culture permeates everything we do in all aspects of end-of-life care decision-making. And I think we can discuss this further. A lot of this has to do with an explanatory model of illness. That illness is culturally shaped in the sense that how we perceive, experience, and cope with disease is based on in our culture's explanation of sickness, explanation specific to the social positions we occupy, and the systems of meaning we employ. In this explanatory model of illness, culture determines perception of health problems, the labeling of health problems, the meaning of health problems, the trajectory of health problems, how we communicate about those health problems, and how we evaluate healthcare. So I don't think, you know, this is, you know, you are all experienced physicians, and I don't need, you know, but you know that we all recognize that in health settings, those in health settings have different backgrounds, utilizing different explanatory models of illness. And these interactions can involve major unidentified discrepancies in the way which we view the problem, values, and goals. And it's up to us as physicians to identify those discrepancies through communication, listening, and understanding. So just in practice, some of the things that can help, you know, what do you think has caused your problem? How does it work? How severe is it? What kind of treatment do you believe is best? What worries you most about it? These are some of the things that you can probe with an individual in terms of what they want to know, what they don't want to know, how they understand their illness, how they interact with their family, etc. One of the myths about culture is this them and us attitude, that culture is brought to us from somewhere else and that it's others. And that in fact, you know, we all have a culture that is shaped by our background, our families, and our training. Healthcare has a culture. And I think we have to recognize that healthcare has a culture that needs to be reconciled with the cultures of the patients that we are managing. And that often within healthcare, even people from similar upbringings, cultural groups, however you want to define that, often their healthcare people come from a position of different status or power. This is one of the things I want to bring up is this idea of using culture as a shield. Biju, you brought this up by saying that you know, the cultural approach of not disclosing illnesses to families is a cultural issue, and I think that's fair enough. And I think it is. I think it can be a cultural issue. But I think we also have to be careful of culture becoming an explanatory black box to be invoked whenever it seems to be convenient or whenever another explanation is not handy. Attributing too much to culture can be as pernicious as attributing too little. And by what that I mean is that, you know, saying that a decision is being made because that's the way that culture does it, or our culture does it, or any culture does it, may be an appropriate explanation. But I think I'd push back a little bit and say, make sure that you're not using culture to explain something that may or may not have a different explanation or way of thinking about things. And then saying that this is a cultural practice, or this is just the way a culture deals with it, may or may not be something that is appropriate. I think it's really important to understand yourself culturally, and this includes your ethical approach. And, you know, what is your cultural background? What elements of this background do you express or believe? How much does this background affect you in ways that you may not be conscious of? And what do you bring to the decision-making process that influences how you interact with patients? You know, and this impacts not only the ethical issues, but really all aspects of how we deal culturally. So again, these are, how does your cultural background affect the healthcare process? What are the culturally based attitudes of the hospital team and your profession toward the end of life care? And I think it's really important to reflect on those. How many of those attitudes have you personally absorbed? Manifestations of culture relevant to the end of life include, so this is just a partial list, and this is again, these slides are courtesy of Dr. Carrie Bowman. Attitudes towards life and death, including fatalism, stoicism, expression of and manifestations of pain, suffering, and grief, acceptance of outside authority and decision-making. We've already talked a lot about this, or, you know, expectations of family authority and decision-making, and gender roles. And I think this is a very interesting quote from Carrie. There is greater intra-cultural variation than intercultural variation. And I remember in one of these discussions I had with a group that include people from not only North America, but also in this case from the United Kingdom. And you know, one person brought up the interesting comment that I believe it was Manchester. She was from a certain part of Manchester, and she said that, you know, the way people in one part of, like, the east side of Manchester would be very different from the west side of Manchester. And so as an external group, we would say, well, you know, everybody in Manchester, you know, comes from a fairly, you know, homogeneous background or whatever. But in fact, even within what we might consider as a homogeneous cultural group, there can be quite a bit of cultural variation. So I think culture, you know, there can be different cultures even between different families. So in practice, I think, you know, I urge everybody to, and I think I'm sure you all do, approach with a spirit of inquiry, listen carefully to the patient and the family, asking the right questions to probe more fully. I think it's important to think about, does the patient or family have a purely biomedical view of illness? Does the patient and family believe the timing of illness should be controlled and the timing and nature of death can be influenced? Is individual decision-making valued, or collective family decision-making? Again, that point's come up several times now. What personal cultural beliefs does the patient and family hold about critical illness and death? Negotiate, clarify what the patient wants to know, and certainly the principle of autonomy means that a person is, in respecting their autonomy, that they have the ability or to know everything. It also means they have the ability to say, I don't want to know things. The autonomy includes the right not to know. And it's important to allow the patient the ability to refuse or not to discuss. Good communication is essential, recognizing the power differentials between physicians and patients. Nonverbal communication important. Remember not to use culture as a shield to explain things that just as a cultural difference when there may be important ethical issues there. To be aware of your personal biases and biases that other members of your team might have, etc. In summary, for this little section on cultural issues, and I'm going to just pause and we can discuss it. You know, respect for diversity means responsibility to respect people's differences and values related to health and illness. We have a moral responsibility to respect cultural differences in how health and illness is understood, experienced, and dealt with. And before I go on to the case, I'm going to stop this and be interested. These are just, again, some approaches, but I'd be interested in your thoughts or comments. Kavan Kumar said also the culture evolves with time. I think that's a really good point. That that I think that as humans grow and evolve, their culture, their culture evolves as they emerge from a family, their own personal family, and how that's impacted their culture, how they're exposed to different friends and people over time. Absolutely, a person's culture can evolve. So again, I think of Canada as Canada is a very multicultural country. In Canada, that means that we are, a country where people from many different countries have come, and we are a country of immigrants, and a lot of our cultural differences extend from people coming from all different countries of the world. But I think the important thing is even people who came from the same country, or even small parts of the same country or the same city, may have cultural differences based on their religion, their family background, etc. I see India as a very multicultural country as well. In terms of the number of ethnic groups, the number of religions, languages, etc., as a very multicultural country. So I'd be interested in your experiences in multiculturalism or cultural care in India as well. Maybe I'll just stop talking now and let you either put comments into the chat, or if you'd like to bring about some comments.
Sir,
Yes.
one of the things we discussed right in the earlier part of our session regarding the theories, various theories you mentioned regarding consequential, non-consequential. So, do we make any attempt to understand the patient's your understanding about this theory so that we align our goals with their goals? So, any kind of activities do we do in our routine practice, or like we practice what is our isolated practice from our side?
Well, I think if I understand the question, I think that notwithstanding that there may be different approaches than an autonomy-based approach, I think we all want to focus on the patient first, their family, and so I think we want to focus on the patient and their family. I think understanding their approach to illness, understanding their goals, and understanding how their goals might be influenced by their cultural experience are essential, really, are essential to the practice of medicine. And understanding that patient in front of you and what their goals are is really important. Now, I think, and trying to ensure those wishes are, and their goals are respected. Ethical issues occur, among other times, though, when the individual's goals vary from the families. Sometimes the individual may not be capable; they may be sedated or unable to make decisions. You may have heard about their goals or wishes, and now that other people are making decisions for them, other family members, they may be making decisions that clash with those values, or have a different opinion. An individual's request, in the case I bring up, the individual requests may clash with your personal values, or may clash with the law, and how to deal with that. So I think that always we want to focus on the patient, understand their goals, understand their understanding of their illness, and try and satisfy their wishes and achieve their goals. But sometimes there can be differences, and that's often where ethical issues develop, is differences between different family members on how they want to approach a problem, how an individual's goals may clash with either your values or the values of the healthcare system or the legal system. That's uncommon, but it can be an issue. And so I think that ultimately, though, and despite critiques of autonomy and sometimes the fact that we may some ethical frameworks would focus a more broad approach to the family, that we are we do need to focus on the patient. Yes, absolutely. Well, I think I'm happy to continue to discuss these. What I'm going to suggest, I'm going to bring up a case now. And I think as we go through the case, I'm going to let you do most of the talking, and I'm going to probe. And this is a case we can, as I said, I'm happy to come back and discuss other cases sometime, but this is really just a case to think about some of the issues that we've discussed today. And all I would ask of you is that as you work through the case, that you think about, if there is an ethical issue, what are the morally relevant issues? How are you justifying the decisions that you would bring forth? And think about some of the principles that we've talked about today, and maybe just the idea is to try and apply some of the things that we've talked about to an actual case. So I'm going to go up to the case now. And again, this is something that was from my practice. We can adapt this to your practice, but I think it's a relatively straightforward from some of the medical issues. And I would be happy to come back for another session where you bring ethically challenging cases and we discuss them. I'd be happy to do that. So here's the case. 75-year-old man has metastatic hormone-refractory prostate cancer to bone. He had received palliative benefit from anti-cancer treatments previously, but that therapy was stopped when his pain was worsening 4 months ago. So there's no other anti-cancer treatments that he can have. He is a widower who lives alone and whose only family member, a son, lives approximately 3 hours away. He is under the care of a palliative care physician and is being visited at home. I've been fortunate to be on home visits with the Pallium team in Trivandrum, and I know that it may not be possible in all circumstances, but we do have that available in some areas of Canada and not. I know that is available in some areas of India. His predominant symptom is pain. His palliative care physician and his team have achieved good pain control. He is also suffering from progressive anorexia and fatigue and is on low-dose steroids for those symptoms. He is cachectic and has lost 40 pounds over the last year. On a home visit, he complains of fever, shortness of breath, and cough, and has clinical evidence of left lower lobe pneumonia. His palliative care physician starts him on oral antibiotics and promises to see him again in a few days. On return, he is clinically worse, and his physician believes he needs to be admitted to a hospital. He states he does not want to go to a hospital, and I'm going to go through a couple of different requests and scenarios in the next couple of slides. And I'd like to see how you would deal with the following requests. What questions you would ask this gentleman, Mr. Jones, we can call him. Under what circumstances, if any, would you comply with Mr. Jones' requests and why? And thinking about, are there any morally relevant differences between the requests Mr. Jones is making in these scenarios? And if so, what are they? So the first request is relatively straightforward. You said that you want to admit him to hospital. He states he has had enough and just wants to stop the antibiotics. So I'm going to open up the chat here, and I'm going to ask, so this is just a request to stop the antibiotics and hear about how you might just deal with that question. And the scenarios are going to get a little more complicated as we go on. And again, I'm interested in if we get back to what we, how would you deal with the following requests? What questions would you like to ask Mr. Jones and why? Under what circumstances, if any, would you comply with Mr. Jones' requests and why? Are there any morally relevant differences between these requests? So I guess the question is his request to stop antibiotics in this, is this an ethical issue at all? So I'm going to stop talking. I'm going to let you guys chime in. You can either put comments in the chat or you can put your hand up to speak or just speak. Go ahead.
I think we should comply with this request of stopping the antibiotics and think in line.
Okay.
End of life care with withdrawing.
Okay.
Unwanted medications.
Okay. So I'm going to ask you. Thanks for that, Bijou. So I guess the question is, how would you defend that ethically? How would you defend that decision on some of the ethical frameworks that we've used?
One is the autonomy of the patient. The patient decides that he doesn't want those treatments because he had enough. So I think I would respect that because I don't see any undue advantage in continuing those kind of antibiotics or such other treatment because his condition is worsening as he's reaching a terminal stage. So we have to stop support him there rather than trying to continue unwanted treatment.
Okay. So thank you. And I guess my question for you is, you want to do this respecting so I think first of all, you said this is an ethical issue. You're complying with his request because you want to respect his autonomy. You've justified. So I would say though that, but on the other hand, we have this principle of non-maleficence, right? That we're supposed to avoid harm. And that by not giving him his antibiotics, he could become more symptomatic. He could die from his pneumonia. So how does your decision reconcile with the principle of non-maleficence?
Yeah, because stopping the antibiotics is not maleficence because that is one of the patient's requests. At the same time, I'm not going to abandon his symptom control. I would definitely take care of his symptoms if he's becoming dyspneic and things like that. I would like to control that by other medications if possible, if he allows it to happen. But again, I will respect his wishes if he chooses to do so, because there is nobody else to talk to. Like his son is far away. He's not in the decision-making process on a day-to-day basis. And it is left up to the patient to tell you what to do and what not to do. I would respect that.
Okay. Thanks, Bijou. So that's. I think that's a very defensible path. So we have some other comments in the chat, and these are some good suggestions. So one is, what is his major concern? Can he call his son home and discuss along with him? Understand why he is thinking to stop the medication, but respect his autonomy, like Bijou has suggested. We can ask the patient what makes him take such a decision. Would the patient like to discuss further about it? Antibiotics are required as he has pneumonia. Try to explain that. So these are all good suggestions, and maybe just going through some of these. I think this is, what is his major concern is a very interesting question because, and as I said, some of these are ethical and some of these are not. But I think that, I guess my question would be, I think this is an important question because you have said you're respecting his autonomy, but on the other hand, say he says that he wants to stop the antibiotics and die. He knows he's going to die perhaps because his pain is too bad. His pain isn't being controlled appropriately. Or he's lonely. And if only his son would visit more often, he might want to go together. These are some great, go ahead. Go ahead.
Sir,
yes.
sorry, madam. You want to say something?
No, go ahead.
wanted to differ a little from what the previous person said. I didn't get your name, sir. Is that one, there is autonomy, but at the same time, yes, we want to do, we don't want to go through the non-maleficence either, right? So wouldn't it be better to have a dialogue with the patient and talk to him as in why he's thinking that way? Because one is correct, the correctables is a very important part. So if there is something which could be corrected, it is better to have a two-way dialogue with him and realize why he is taking such a step, and then attempt to convince him in case there is something which is convincible, rather than just accept that.
Okay, so I think that that an approach of respecting autonomy is a good approach, but that these are some contextual issues that may be helpful, and there are things maybe about symptom control, why the patient is making this decision, what they would like to discuss further. But I think Punithavathi has an interesting comment that it's financial burden. Or a number of things. Is it financial burden of going to the hospital? Does he not want to go to the hospital because he can't afford it? Is it the physical burden of just, of having, that he's really, his symptoms are controlled, he's happy with his relationship he has with his son, but he just does not want to, go into the hospital and have more invasive medical care? Is it the non-availability of caregivers? Is just not having his son around, or other supports? Yes, go ahead.
So I had a similar patient, but she was not cancer patient, but she was end organ failure patient. She had end stage cardiac failure, and the cardiologist, she didn't have anything else. She had COPD and she had cardiac failure, but she was almost at the terminal stage, and the cardiologist was taking care of her. He was treating her cardiac failure, and one fine day morning she said, "I had enough of all your treatments, so stop it and let me die." So he didn't know what to do. And then he called me and he said, "Can you take over?" And then she came to know that I'm a palliative doctor. And I said, "Yeah, I want your treatment. So I don't want the other doctor's treatment." I said, "Okay, what do you want?" Then I discussed the case. I said, "Why are you stopping the treatment?" I said, "I want to die." I said, "Okay, but why do you want to stop the treatment? We can make you feel better, but it might be only a little bit of time before things turn for the worse." But she said, "No, categorically no, this is it." She was so adamant. She knew exactly what she wanted. And in addition to that, she asked me for euthanasia. I said, "That's one thing I can't do. So I will help you." But she was in pain. She said, "Okay, in that case, you take care of my pain." So I had no other choice other than to stop all the other treatment. And she would accept only morphine subcutaneous infusion just to control her pain. And so you won't believe, she lasted almost for 2 weeks with that kind of dyspnea, that kind of, problems. But she was suffering that. She knew that she was conscious, but at the same time, she just wanted to take care of her pain. And so it was very harrowing for me also, in the sense that, as Madam was saying that, correct the correctable, treat the treatable, we can, but she was absolutely refusing that. So I had to honor that. But she had a very, very good death because she did not have any dyspnea because of the morphine. We controlled it so well that her symptoms were controlled, and she passed away very peacefully towards the end. So this is one of a similar case which came to my mind. That's the reason why I said, I think we should respect the autonomy.
Right. So I think that what I'm hearing from the group, that in this case, I think that there's been a number of good suggestions about things that could be explored. What is the symptom burden? And is what this request to stop treatment, is it related to symptoms? Is it related to social isolation? Is it related to financial burden? There's a number of other contextual issues, but as you say, Bijou, you may go through all of those and say, "No, my symptoms are fine. I'm perfectly happy with my life and family life. It would not be a financial burden for me to go to the hospital. I just don't want to." And then ultimately you respect the decision. But you brought up another interesting idea, and I'm gonna, so my second request, and remember, so this is, I'm gonna put a new twist into this now, is that when he says that he states that he has had enough and wants to stop the antibiotics, but then he says he also asked the physician to give him some pills so he can end it all. And Bijou, you've actually said that you've actually had requests for euthanasia, and we can use that as a term right now. And people may want to share or not want to share about people who not only say, so I think that the first case is a case of, you know, if the patient is capable, if they're of sound mind, and if you've gone through them and there's no financial burdens, family burdens, symptom burdens that are influencing their choice, and you've addressed those, respecting a person's request to stop an antibiotic or therapy is something that generally we should respect, and I think we hear that. But you know, at least Bijou has told us that he's heard in his practice a request for euthanasia or to end his life. And in this case, I'm now saying that this person is actually asking for some pills so that he can actually end it all. And you know, I think these requests I've not had many of these in my practice, but I've had a few over the years. And the question is, so this is going to put an extra wrinkle into it ethically and morally. Legally, I think you've also brought up, Bijou. How would you deal with this request, that if he wants some pills so he can end it all?
As I said, it depends upon the place where you're working. If it is against the law, definitely no. But as in India, but at the same time, with regard to my moral obligation to the patient, I would not admit to that, because that is against my belief that we should, you know, knowingly do that kind of thing in our practice. But one thing I can say that if palliative care is given in the right way, in the right time, in the right mode, I don't think that there is any need for euthanasia, because this is something which I've read in a paper in Switzerland where euthanasia is legal, that many doctors, when this law came into practice, many doctors started hastening the process of telling the patients to go for euthanasia. They were almost pushing the patients to euthanasia because they could not bear the pain. But later on, after some time, they regretted, saying that, you know, had they deferred that and taken care of the pain better, they may not have requested it, because most of the time it's the incessant pain which is driving the patients to ask for that. But once the pain is relieved, like in this case, she was quite happy to be in that situation where she was not having pain, but at the same time, she was not bothered about the fact that she's dying.
Okay. So you brought up a lot of interesting points there. Thank you. So I think a couple things is that ethics intersects with the law, and that in India, this request, and I'm going to say, like, you know, this request, the request could come either to give the person some pills so they can take them, or the request might be to give them some type of injection to die them. You've said that it's illegal. You said that even if it was legal, you would you don't feel this is appropriate. And I think a couple of things. One is that you don't think that as a profession, and forgive me if I'm paraphrasing you improperly, is that as a profession, this is not something that should be done. And that's an appeal to something we haven't talked about, which is professional ethics, that even if this was, yeah, go ahead, yeah.
So I was in curative medicine for 40 years before I came into palliative. So my first instinct was always to save the patient. So that was always kicking in. But at the same time, when I came into palliative and started realizing that, you know, there is an end to everything, and end to life for everybody. And the principle which we were following here was to give dignity and take care of the patient's symptoms as much as possible, to see that the patient doesn't suffer and their relatives also don't suffer. And if I can do that to a lot of extent, I would say that I would prefer that rather than ending the life of the patient. At the same time, I've had situations where I had to go and give terminal sedation for people with intractable dyspnea, you know, unbelievable in one case, she was literally begging me to kill her. But I did start terminal sedation in the patient, but that was not with the intent of shortening her life, but that was the only thing to do appropriately at that time. She lived for about 18 hours before she passed away, and her daughter was actually thanking me for relieving her symptoms because she died in her sleep. So all these things, it's very difficult to quantize in one shot, like one size fits all. We have to look at each situation and then manage it accordingly also.
Right. So these are some great comments. And I think maybe just again, some of the things you brought out, matters of professional ethics, that even if this was legal, this may be contrary to the profession or the ethics we have as physicians, that even if the request was legal, that it would clash with your individual morality and your ability to do this. I think that Parul has brought up the idea that if it's against the law, requestfully no. I will try to explore more. Is this because he is lonely or he is tired of his symptoms and work accordingly? And I think that you brought up, Parul, thank you for that. And Bijou, you also brought this up, and certainly palliative care physicians in Canada also bring this up, which is that if people get outstanding palliative care, if they're, and this palliative care to relieve their suffering, and this means not just symptomatic, but, spiritual, familial suffering, etc. If there's great attention to, relieving a patient's suffering through all the means possible, that there's really no need for, in Canada now we call this medical assistance in dying. So I think that these are some excellent points that come out. I think the other point that you brought out is around terminal sedation, which is a very interesting one. I'm going to park that for now because I think I'd like to talk a little bit more. So let me just tell you a little bit about. I've been teaching about ethical issues in end-of-life care for 20 years, and for the first part of my career, I always had to say that in Canada, like in India, if you felt that the patient says, made a request to end their life, so not just saying I want to stop the antibiotics, but I want to stop the antibiotics and I want you to end my life, I would have to say that is illegal in Canada. And if you choose to do that, if you feel that that's ethically justified, you could be ethically justified, but you would be in contrary to the law, and you'd have to suffer the consequences of that. In the in June of 2016, medical assistance in dying was legalized in Canada, and so that.
So having said that, sorry to cut you in. Having said that, in India, just last month, about now 2 months ago, Supreme Court directive has come where advanced directive or living will has been accepted as a part of a legal document. That is, if the patient wants to, in sound mind, when he's in sound mind, if he wants to say that, he doesn't need any resuscitation or any ICU or ventilation kind of treatment, then that has to be accepted by the doctors. And this is a new thing which has come into India, because previously also this was there, but it was a very vague kind of thing, because there it needed to have a magistrate to certify that, and at the same time then he would give it to a medical board to ratify it, and by the time the patient would have already died. But this has made it more simpler. So it's just happened in the past, I think now 2 months ago. So
right. So there's lots of interesting. So first of all, I realize we only have about 15 minutes left, and lots of other interesting topics are coming out, as they will. There's lots of interesting topics to discuss, and Sunil Kumar, I will offer to come back with this group. This has been a great discussion. I really enjoyed it, and I'm happy to come back, and if we run out of time in this session, have discussion about, as I said, bring cases. So in case of advanced directives, that's really good to hear, in the sense that this is actually an area of specific interest to me, and I actually in my earlier work developed an advanced directive for people with cancer. But the important thing is that it's good to hear, because if we respect that idea of autonomy, often a patient like the one we discussed, when it comes time to go to the hospital, or when it comes time to be considered about whether to be put on a ventilator, they may be incapacitated, they may be delirious, they may be unconscious. And I think that, on the other hand, in many cases, prior to them becoming delirious or unconscious or whatever, they may have clearly expressed their wishes. I do not ever want to go into a hospital, right? Again, I want to stay at home no matter what. And that's after exploring all the other issues. I never want to be put on a ventilator. So, but if they're not able to express those wishes, I'm glad, and this is true in Canada as well, that they have that ability now in India to, and this is ultimately about respect for autonomy, that ability through advanced directives. I'm going to come back a little bit though, so to talk about this idea of medical assistance in dying, and maybe just talk a little bit about the Canadian experience, if you'll forgive me. So there's now been a study in Ontario. So it became legal in Ontario, in Canada. Ontario is a province within Ontario, about 15 million people, small by Indian standards. But in the 2 years between when it became available in June of 2016 and about 2 years later, there had been 2,200 patients who had gone through medical assistance in dying. So even though in my practice there had been very few requests, in our relatively small province of 15 million people, in 2 years, there were more than 2,000 patients who had made a request to end their life. And physicians do this through sedation or through injection. One of the concerns was, as you brought up, were that they would not have, that one of the things driving this would be lack of access to good palliative care. So what they looked at is, of these 2,200 patients, so they looked at these patients, and they tended to be younger, had higher income, were substantially less likely to reside in an institution, and were more likely to be married than people who died from the general population, suggesting that medical assistance in dying was unlikely to, in this context, to be driven by social or economic vulnerability. However, they were able to show that there was a high level of high prevalence of physical and psychological suffering. And the conclusions of this study were that, given the high prevalence of physical and psychological suffering, despite involvement of palliative care providers in caring for these patients, future studies should aim to improve our understanding and treatment of specific type of suffering that lead to a medical assistance in dying request. So, so a couple of things here. These types of studies do not define ethics. They don't say what's right or wrong. But I think, coming back to your point, Bijou, that you made, is that certainly this concept that if there is truly total palliative care and optimal palliative care to relieve suffering, it may reduce some of these requests. But I was actually surprised by how many patients had gone through this in my province. So Punithavathi has said, I recollect one of my experience, we had parents of a post-op cyanotic congenital heart disease baby, been on a ventilator for 21 days, coming and telling me, now please give an end if we can't see the difficulties she is undergoing. So after reviewing all the curative possibilities, we decided not to escalate any treatment and continue the same. Without a pain relief in 2 days, the baby passed away after we stopped hiking oxygen and inotropes. So I think that brings up another interesting, thanks for sharing that, Punithavathi. I think that is a case where exploring the medical options available, a decision was made to stop or to not escalate therapy. And most of the time that is not considered medical assistance in dying. I think the issue there obviously is that making those decisions for a minor, in this case an infant, and I think that in most cases, most societies would understand that parents have the ability to do that, and and so the question is, sometimes though in Canada at least, we have situations where it became clear for the doctors that continuing treatment would be medically futile, but the parents may want to continue therapy, and there would be a clash of, and again, these are often where the ethical issues arise, is when there's a disagreement. So I'll pause there because this has been some excellent discussion, some excellent things in the chat. We brought up a lot of issues, and I think, again, when we talk about these, and the reason why medical assistance in dying was made legal in Canada was that this was the kind of the classic clash between two different ethical frameworks. The one saying that there has to be a respect for autonomy, and that if a patient expresses a conscious and capable wish to die, that should be respected. That clashed a lot with deontological views and previous laws, which said that killing, including medical assistance in dying, how this is phrased, is always wrong. It may be wrong. You may say it's wrong because it clashes with the law, because it clashes with your religion. Killing as physicians is something we shouldn't do as a physician, but killing is wrong. And that's a deontological view. Consequentialists would say that, medical assistance in dying brings about good because it's respecting autonomy, reducing suffering. And again, for many years, and still in many countries all over the world, that deontological view holds. It's against the law. And yet in many, you mentioned Switzerland, parts of the United States, Canada, many other countries, it's now legal. And I think this also, one of the comments brought up earlier, that cultures and societies evolve, right? So I think that how we address these medically ethical issues evolve within societies and cultures. But I think that it's often important to understand, and these debates go on in Canada, and the palliative care physicians are advocates, because I believe many palliative care physicians believe that this is really the discussion should be about making sure every patient has access to the best possible palliative care, and not about medical assistance in dying. They're not mutually exclusive, but that's often brought up. There are some palliative care physicians who feel that medical assistance dying is part of reducing suffering and part of what should be offered by palliative care. And again, these are not wrong or right. These are just different things that are being brought forward. It's 10:54. I think we've had a really good session. I was hoping to learn from you, and I appreciate your engagement and contributions to this. I've learned a lot, and I've enjoyed this. I just want to make sure that we have time before wrapping up today. I'm happy to take, I have a tendency to talk too much sometimes, so I have any questions or comments before we wrap up. And I would be happy to come back again with this group and have another session where, and I would suggest the session would be cases that have caused you moral or ethical difficulties, moral quandaries. And I would be happy to lead a discussion going through some of those cases based on some of the frameworks that we've discussed today. But maybe in the last 5 minutes, if there's any questions or comments that people would like to discuss. Thank you for your engagement. I've really enjoyed this.
Any comments from anybody?
So maybe I will take the last few minutes then. And again, please, because Viju did bring up one other thing about terminal sedation. And this is actually something that can come up where somebody is in terminal sedation. How does that differ from medical assistance in dying? And I think the ethical principle that's usually brought up here is the principle
the double effect, the principle of double effect.
Principle of double effect. That's right. And the principle of double effect states that you know, if the intent of terminal sedation is to relieve suffering, not to cause death, therefore it's morally justified because, you know, a patient's consenting to that. And even in places where causing death is illegal, like India, the terminal sedation is justified because the intent is not to cause death, it's to relieve suffering. What's the biggest, can anybody think of a criticism of the principle of double effect? The primary, and I'm just going to bring this up because we only have a few minutes left, the primary criticism of the principle of double effect is it relies on intent. And intent only exists up here, right, in the palliative care physician's head. And
so, but you know, practically, when you come to that particular situation, you know, it's so harrowing to watch that, including the relatives themselves say, please put an end to this situation. You know, that is when you know that you're going to do the right thing. I mean, when you said the intent, you know, that is when I make my decision that, you know, they have to go into a terminal sedation.
It's true. Yeah. And I think this is where I think I agree with you. There's no doubt you're doing the right thing. But if you said your justification is that my intent is to relieve suffering, not reduce pain, often the way intent can be discerned is by, you know, if somebody says, I'm giving, you know, X milligrams of whatever sedative or pain relief, I'm doing it in a logical way and increasing, you know, in a judicious manner, then the intent is to relieve suffering. If you give, you know, 10 times the normal dose of something, you can, the intent you could say was not to relieve suffering, it was to cause death. But I'll tell you something though, is that one very wise palliative care physician said to me once, you know, the principle of double effect is very clear that I'm supposed to be relieving suffering and not to intend dying, and the intent is there. But they actually reflected that, and maybe this is what you're referring to, Bijou, that in that really moment when you're actually, you know, giving that next dose and saying, what is my intent here? Is it to relieve suffering or to cause death? They were really not clear anymore what their intent was. And I'm not saying that's right or wrong. I'm just saying with the principle of double effect, it relies on intent. You know, that even the intent might be to cause death. And I'm not saying that's necessarily wrong. In Canada, it's no longer illegal. I'm just saying that because it relies on the person's internal practice, it's sometimes difficult to discern.
So, but at the same time, in all these situations when I have done that, I've explained this very diligently to the relatives because the patient may not be aware of it. And at the same time, I have taken informed consent from them. I said, I will not be able to do it without the consent. So that is something which I take care first before I start the sedation, because that is for the legal side of it. I mean, whatever it can help.
Yeah.
Because if there is because what happens that sometimes there are 3 or 4 children, and in I don't know, you know the situation about Kerala.
Right.
Most of the children are abroad. They're not with the parents. So 2 of them might be in the United States, 2 of them are in India, and it will be the 2 who are in India who are taking the call, but the 2 outside will be disputing it later, and then you can be in problem. So I always tell them, you have to make the final choice, but at the same time, give me the informed consent so that I can start with it. That's what I do.
Yeah. So I think that's the final word. All I would say is it's been a great pleasure. I think, as I said, I had a chance to meet most of you previously, but it's been really a pleasure to work with this group of Pallium fellows and to meet you in person and work through. You're obviously a very engaged, motivated, and highly interactive group. So what a great pleasure. I hope I have a chance to work with you again. I'd be happy at any time to come back and discuss more ethical cases. Thank you very much.
Thank you, sir.
Thank you, Scott, for that interactive session with the case presentation, and also for introducing another ethical approach in terms of deontological and utilitarianism, etc.
Yeah.
So I hope, yeah, I think Dr. Kushbu has a question. Dr. Kushbu?
Okay, go ahead. Yeah. You're muted, Dr. Kushbu.
Yes, hello, sir. Good evening. It was a very excellent, very nice presentation. Thank you for that. And I wanted to ask that at this level, can we introduce the spiritual gurus or the psychologist and or psychologist for the patient at this stage when all this we are talking about euthanasia or you know, I mean, can
So
we introduce?
I actually, yeah, I think introducing spiritual or religious gurus or priests or whatever is very important, because part of the issues in end of life care can be spiritual suffering, and I think that ensuring that they have appropriate spiritual support is really important. And what was the second part of your question? Spiritual gurus and
the psychologist.
And psychologists, absolutely. And in fact, one of the things in the Canadian system in terms of medical assistance in dying is that a psychiatrist actually is involved to make sure that the person is making a capable choice, that they have the capacity to make the decision, and also that there's no underlying psychological or psychiatric issue like depression that may be needed to be treated that's leading to this request for care. But I think that absolutely psychosocial support and addressing spiritual or psychosocial suffering is a really important part of this. The man we were talking about, all he may have needed, or one of the things he may have needed most, was psychological support around being lonely, being reconciled with his son, etc. So I think that this is a team effort. It includes medical team, nurses, psychologists, spiritual members of the spiritual community, etc. Because the goal, I don't need to tell you, is to relieve all those types of different suffering.
Yes. Thank you, sir.
Thank you. I'll send a copy of my slides if that will be helpful.
Yes.
Thanks, everybody.
Yeah.
Have a great day.
Thank you, Scott.
Or have a great evening.
Thank you, everybody.
Okay.
Thank you, Scott. Thank you for joining us. And we know that you have a very busy day ahead. So please continue with that. And thank you everyone for joining and making this session also interactive as usual. And with a gentle reminder that we will also meet him tomorrow also with another interesting session and two eminent faculties. This is Sripriya along with Dr. Scott and Dr. Sunukumar signing off. See you tomorrow again. Till then, everyone take care. Bye-bye.